Friends, today we will be talking about pre-myopia, which is the third chapter of our myopia progression control course. Now we know what is pre-myopia. We know pre-myopia actually means that something before the actual myopia sets in, something that happens mainly as a part of developmental curve, as a part of developmental growth of the kid. So we know that eyes would progress gradually starting from birth till adulthood. Now there are compensatory mechanisms in the eye with corneal curvature actually gradually becoming flatter and flatter to compensate for this axial growth, and also anterior chamber becomes deeper and lens becomes more and more slightly more thinned out to reduce the amount of myopia which is being generated by the axial length. And we know that in premature babies, mainly because of the steep cornea and because of the fact that there is crowded anterior segment, we do have myopia even when the axial length is not much. So there is not much of axial growth in premature kids, whereas there's a good lot of axial growth in normal kids who are prone towards myopia or who have risk factors of myopia. So the point is that premyopia is actually a new term for truly an age-old condition which is precursor of myopia. More and more people have now recognized that premyopia is important, and that is truly because we have understood that once the myopia sets in, it becomes very difficult to control the progression. Whereas it's a good way of handling the kids if we can find out what are the risk factors, which one of these patients would progress, what are the precursors of myopia, and if we can truly actually prevent any kind of myopia, that would be a great advantage for future generations and also for reducing the actual medical disease burden on these particular kids. So let us see what premyopia has. So what exactly is premyopia? So premyopia, in their one of their articles of International Myopia Institute, they have defined premyopia as a refractive state of an eye between plus 0.075 diopters and minus zero point 0.5 diopters in children, where a combination of baseline refraction, age, and other quantifiable risk factors provide a sufficient likelihood of the future development of myopia to merit preventive interventions. Now, see, it is very easy to criticize that why a plus 0.75, why a refractive status or a refractive state of a particular eye which has a power of plus 0.75 is being called for any preventive interventions, which is very clear here by saying that it is the age and other risk factors, which may be family history or near work or a definitive history or a definitive likelihood of reduction in hypermetropia and increase in axial length over a period of last 1 year or 1.5 years. And these children are obviously susceptible towards progression towards myopia, and thereby these patients would definitely need preventive interventions to stop the growth of eyeball and to reduce the chances of patient developing myopia. Obviously, if at an age of 2 years, if you have a hypermetropia of plus 0.75 with some history of family history of myopia, there is great likelihood that these patients would go upon being emetropic very early and gradually becoming myopic as the time goes on. So that is the classic definition of premyopia. The range is because otherwise they will have to give a range of age. So we will see what are the risk factors as per age, which have also been now have been defined, though there are the studies are yet to come out regarding the validation, but there is definitely some scoring systems which have been devised to find out which patient would go for premyopia. So what is currently known in premyopia? We know that it is the baseline power, which is very important. Apart from that, the second risk factor is parental myopia. Now sibling myopia is actually a risk factor. Not many people agree to it, but sibling myopia is definitely one of the important risk factors. But parental myopia being a more important risk factor compared to sibling myopia, with both the parents not being myopic, the sibling myopia is not truly a big risk factor. And then there is baseline age at which this baseline power is being defined. So as I said, if your power is plus 0.5 at an age of 14 years, it may not truly be a risk for premyopia, but the same power of plus 0.5 at 4 years may be a risk factor, especially super added with parental myopia. It is a definitive risk factor for premyopia. So this is these are some of the cutoff ages which I have taken, and this is just to show you a graph as to how many patients and family history and what are the what are the cutoff for predicting myopia by the age of 13. So a child who is 6 year of age would develop myopia by 13 year of age. The predicting factor obviously would be plus 0.75 at the age of 6. And we saw that video on Branholden Vision Institute risk factor analysis, or rather a calculator, and I showed you that you can actually go there, and if you see there, if you try to drop down the menu, you will find that it is actually the the most important risk factor is what is the age, what is the baseline value, and whether there is parental myopia or not. So by the time you realize that at 7 to 8 years of age, plus 0.5 is definitely a risk factor for developing myopia by 13 years of age. Overall, other risk factors, like I said, parental myopia, near work, low outdoor sitting are definitive risk factors. Another important point is that any child who is losing hyperopia quickly between the visits, if if presumed imetrope loses zero point 0.5 or more for age normal hyperopia in a year, this patient is very likely that this patient would go into a future myope. So if a patient presents to you 6 year old, has plus 0.75 and comes back to you after 6 months or 8 months and is emetrope or is only 0.25, and again comes back to you in 6 months with having minus 0.25, this patient definitely has myopia. The chances of myopia are very high, and the good thing is to start taking axial length very early for children who are borderline hypermetropes. So this borderline hypermetropia is known as the hyperopic reserve. We'll come to that in coming slides. But if you have a very small hyperopic reserve, family history of hypermetropia, lot of near work, you should do a baseline axial length so that you can easily find out whether this particular patient is gradually increasing in terms of axial length or not. So these are the risk factors. Ethnicity, Asian are at high risk. We fall into Asian. Family history, one of the patient is myopic, threefold increase. Two of the patients are myopic, fivefold increase. Less than 90 minutes a day spent outdoors, and less than 3 hours, more than 3 hours of near work would contribute to visual environment, which contributes to the fact that these are the risk factors which would lead the patient for myopic progression, and gradually they will end up being myope even if they are hypermetrope at this point of time. So this is what is truly the pre-myopia. Now risk factors, if you see, this is one of the wonderful articles where they have tried to predict who will develop myopia, and I have asked Devanshi that we will be doing a small journal club or a small critical review of this particular article, because I think bulk of the evidence at this point of time which is being circulated comes from one of the articles, which is this. And they tried to calculate two major risk factors which were taken as baseline cycloplegic refraction and baseline axial length, and they found that baseline cycloplegic refraction was a more strong or corroborative factor which was being correlated with the age. So we will see all the three things. So the first and foremost thing is, if you see this, you can see the baseline refractive error and their scoring system. So at the age, if you have a spherical equivalent of 2 diopters, or 2 to 1.5 diopter, 1.5 to 0.5 diopters, and the parent is myopic, scoring system is 2 or 4, the validation cohort, they did the scoring and then they tried to validate it as to how much useful this would be. And the second factor they tried to calculate was baseline axial length. You can see this was the score when we kept at this age, male female gender. This was the axial length, 22, 22.4, 22.5 to 22.9, and this was the antechamber depth taken, uncorrected visual acuity taken, And the third factor was axial length upon CR ratio, which means that axial length divided by the corneal curvature radius. And so then what they did was, out of these three things, they tried to make a scoring system, and that particular scoring system was similarly taken up by the NICER study, very similar to what they have done versus what is the predicting myopia onset and progression scoring system. And this is very similar, and so will take up this as a scoring system, because currently most of the people are using this particular scoring system, especially for pre-myopes. So in this, there is, first of all, you have to find out the age of the patient. If it is between 6 to 8 years of age, if there is parental myopia, the score assigned is 0 to 3. The next thing is, if the cycloplegic refraction spherical equivalent is greater than 1, there is 0 score. Between 0.75 to 1, 2, and less than plus 0.75 for age of 6 to 8 years. And if axial length is more than 23.19 millimeters, the score is 3. Now, once you have this score, you will have an overall score. If cycloplegic this thing is not available, then non-cycloplegic estimations for scoring factors are this, but we mostly would be dealing with these patients. And then you have to extrapolate your number here. No, not here, sorry. Then you have to also see in terms of K reading, because we saw axial length upon corneal radius ratio. So then you have to take that K reading here, and if K reading is available, if axial length is unavailable, then you can go to K reading, or else you can take K reading also as an independent risk factor. And this is the same thing for 9 to 10 years of age. Now, once you have 1, 2, 3 total risk score, you have to add the three things. And here you have to add the three things, and then if your scoring system is 0, there is absolutely no risk. What you have to do is, you have to call these patients after 2 years. So if the likely to remain emetropic, little or no risk of development of myopia. Having said that, you should always tell the patient that you can revisit after 1 year or 2 year, and we can reassess the kid. If there is low risk, moderate risk, or high risk, there is likely to be myopic at the age of 16 years, at the age of 13 years, at the age of 10 years. So you have to call them on follow-up after 1 year, and you have to reassess if they are losing their myopia too quickly. So what my point here is that if you feel that their axial length is progressing faster than what it should progress, or their hyperopic reserve is going down much more quickly, then we have to start some anti-myopia progression treatment. Now, in this, if you in this particular point, when should you call these patients? So if the age of the child is 13 years or more and score is 0, and if there is annual progression, so this particular thing is based on the myopia progression. That particular thing was based on the fact that whether this particular patient will progress or will not progress, whereas this particular chart shows you that if patient is coming routinely to you, and if annual progression is less than 0.5 diopters, and or if it is more than 0.5 diopters, the scoring system is 1. So if you have a patient whose score, this is purely based on myopia progression, this is not under pre-myopia, this is purely under myopic progression. If you have a patient, and if that particular patient is progressing at a score of 0, you can call them after 2 years. If there is moderate progression of myopia long term, 1 year, and if there is very fast progression of myopia, high magnitude of myopia can be there long term, and you have to call this patient every 6 months. So this was the part 2 of predicting myopia onset and progression chart. I took it here, but this is not for pre-myopia. This is just a follow-up schedule for that. Now, this was a study done after this particular pre-myopia onset chart or validation system came. This particular article validated the pre-myopia onset risk indicator for predicting myopia onset in children. We have currently acquired the data, and we are trying to validate it for Asians. But for UK patients, a pre-myopia onset risk score of 4 is a strong predictive indicator for future myopia onset. So a score of 4 at this point of time for UK children has been suggested to be it should be carefully monitored. And this is more data on what is likely to be myopic. This is what we have already seen. This chart is similar to what has been published. This is head-to-head a comparison of UK children with Hong Kong children. And the UK children, they only had a data set of 6 to 8 years of age, so we'll only compare that, and the data set was very small. They only had 57 patients. And if you see the sensitivity of scoring risk cutoff score, if it was kept at 4, you can see a sensitivity of almost 0.97, which is very good sensitivity, and a very good specificity of 0.96. And for Hong Kong children, a score of more than 4 gave a very good sensitivity but a very low specificity, and false positive rate was 0.36. Whereas if you keep a cutoff score of 4 out of 6, again very high sensitivity but relatively low specificity, and 0.28 were false positive. So this scoring system works very well for UK patients in age 6 to 8 years for predicting which patient would convert into myopia. So what is hyperopic reserve in all this? So the amount of hyperopia in a child with a risk of myopia due to various risk factors is hyperopic reserve. Now this is a wonderful, this is again taken from the Asia Pacific 2023 study. You can see that if the myopic reserve, that is what we have been talking about, what is the myopic reserve, how much is enough? So if you see, if there is a myopic reserve of 0.75, the chances that this particular patient will lose that hyperopic reserve is very low, and there are good chances that at the age of 8 years, if the child has a hyperopic reserve of 0.75, it is good enough for the child to go through that by the end of their teen ages. So parental myopia is an independent risk factor, and if the patient has parental myopia, the hyperopic reserve should be more by around plus 0.5 to plus 0.75. Also, another factor is progression each year. So despite these two factors, if patient is progressing very rapidly, I think those particular patients can be put on atropine if you have data, if there is evidence that this particular patient is gradually shifting towards myopia and would have an early onset. Also, axial length upon CR ratio, not very sensitive, especially for premyopia, but yes, it should be taken, because once the patient is closer to hematropia, you would see that there's a change in axial length upon CR ratio, and that is also a good variable which can be shown to the patient that this particular axial length versus CR ratio is also gradually increasing, and this patient is more likely to convert into myopia. So how to manage premyopia? Now premyopia is more important than preventing myopic progression. We have seen that. Why? Because these are the patients who are not actually myopic. So you are doing a great service by not only preventing myopic progression, but also making sure that these particular patients will not be having that generational progression of myopia. So that is very, very important. It is very important to communicate with parents, because parents have to understand that our kid is not truly myopic, but there is a good chance that he would become myopic. Here it is very, very important that if parents are myopic, there is a very good chance that they will easily understand and would follow what you are saying. However, if they are not myopic, then it becomes little tricky. And very important is to communicate with fellow colleagues, because if your fellow colleagues do not understand who is a pre-myope, or you are treating a pre-myope, he would easily tell the patient. If the patient comes to you and you have given an opinion, or you have started atropine eye drops, and patient goes to your fellow colleague, they should also be aware that there is a condition which is premyopia is there. This particular patient has been diagnosed as pre-myope based on few criteria which you have taken, or based on some risk factors, or based on quickly losing out on myopia in last 1 year or in last 8 to 10 months. So it is very, very important to keep communicating with the fellow colleagues that these things are actual and these things are real, because sometimes you may tell the patient, and patient may go for a second opinion, and they may be misguided for the fact that premyopia does not exist, and we will treat myopia when it comes. So that is also very, very important. What would work? Everything works. The best thing is to tell them about lifestyle modification. Parents would just love it when you tell them that the kid doesn't have to use mobile. They are already fed up that their kids are using mobile, and they only want a vent out. They only want someone to say, or someone to bell the cat that this particular thing is happening, and this is the problem because of overuse of mobile or overuse of screens. So you have to make them understand that it is not just the screens, but the near work, but sitting indoors, waking up late at night, all the factors which are responsible for myopia progression would be applicable to premyopia. Does atropine work for premyopia? Of course it does work for premyopia. Do optical glasses, does peripheral defocus work for premyopia? I don't have personal experience with that, but there have been some reports where they have suggested that it would work as good as it would work in a case of myopia. So lifestyle modification plan, very, very important. All the pre-myopes should be understanding at the beginning of this itself, because at some point of time they would need a proper treatment for myopia progression. So if you have already put your things in place that there is a need for increased outdoor activity by at least 2 hours a day, decrease near work at 25 to 30 centimeters, or even more for cell phone, tablet, and even for reading and writing. And maybe you can ask for vitamin D, refined carbohydrates, which have been suggested anecdotally. There is no evidence based or true randomized control trials that these things would make a difference or not, but still you can use your popularistic measures by saying that vitamin D can be given, or refined carbohydrates can be reduced for to reduce the progression of myopia. Having said that, you always have to stress that it is the increased outdoor activity and decreased near work which would be making a significant impact, rather than vitamin D or refined carbohydrates. So workup for premyopia, there are some tests you must do. This is very similar to what we have already seen for myopia progression. So I will not go into a lot of details of it, but we will just touch upon it. Must do, obviously, you will be doing visual acuity slit lamp examination, cycloplegic refraction fundus examination, intraocular pressure keratometry, and axial length. And now you will add axial length upon corneal radius ratio, since you have already done axial length and keratometry. It is what are important workups. You can always do a baseline topo. You can do a baseline peripheral refraction, open field autorefractor if you have. Binocular vision assessment, yes, it should be done, especially with low hyperopes. Tear film assessment, accommodative lag should be done. Uh, you can do a pupil size or choroidal thickness aberrometry, pachymetry macro thickness, and pattern ERG if you are suspecting anything in specific. And so that was the small thing on workup of premyopia, which is not at all different from what has already been done for normal myopic patients. Now, role of low concentration atropine, why I am taking it up here is because for premyopes there are very few studies where they have actually used atropine, and this is one of the major studies by Fang et al. Where they have shown that the refraction of less than +1 was taken as a cutoff, and they found that over a period of 1 year, 54% in the control group progressed past -1 diopter, while only 21 did in the treatment group. So they felt that atropine 0.02% does work for premyopia. And then atom 3 is also doing some work on premyopia. Uh, However, if you feel that the child has esophoria, high AC by ratio, or accommodative lag, correcting with spectacles for near may be a great option. At this point of time, there is no evidence that myopia control or contact lenses will help in pre-myopes, although there have been few reports where they have suggested that even for pre-myopes, you can give glasses with zero power. You have the peripheral defocus lenses, and this was our experience with low concentration atropine eye drops, which we published in 2022. And we found that the baseline progression. So we went only and only for progression all the patients before starting the drops did have baseline progression, and at the end of first year the mean progression in the low concentration atropine group went down by minus 0.31 versus 0.76 in the control group, which was already progressing by 0.69. So there was no change. It was progressing at almost 0.69 and kept on progressing even afterwards, after for the first year, because we those patients did not put low concentration atropine. At the end of second year, the mean progression compared with baseline was reached up to minus 0.6 diopters versus 1.75 diopters in the control group. So there was a huge difference. By the end of 2 years, the mean myopic progression was there was a huge, almost double the difference between low concentration atropine and in the patients who were not putting it. Yes, there were patients who, despite putting low concentration atropine, did increase. I think we did not take them in this particular study. So in our understanding, we have now understood that we would divide these pre-myopes into two broader groups like type 1 and type 2. I know this is not published. This is purely based on what we are doing at this point of time in our clinic, or what we have understood. Type 1 is purely based on the fact that they have a parental history of myopia, whether there is one parent is myope, or two, both the parents are myope, or one of the both parents have high myopes, or parents and sibling, all of them are myopes. Whereas type 2 is straightforward, none of the parents are myopic, but there is high near work or screen time and less outdoor activity. So type 1 pre-myopes do have a higher chances of progression, and they become myopes at a younger age. So in our data of almost 250 children, at least 188 progressed over a period of 2 years, because some of the children were not there for 2 years. Some of them were for 1.5 years or 1 year. When both the parents are myopic, the chances are much higher. Low concentration atropine has higher non-responders in this particular group versus the other group, and this obviously needs a more stronger drop and needs a higher concentration atropine. And whereas type 2, the progression is slower and slightly later, they present to you slightly late. Environmental progression should be suggested as a first intervention whenever they come to you as a pre-myope, and it responds well to atropine 0.01% and 0.05%. We know that atropine is a dose dependent drop, so 0.05 definitely works better than 0.01%, but 0.01% also works. And if there are no evidence of progression in a patient with minimal risk factors, then it may be preferable to observe such cases if you do not have any evidence of progression, and then you should keep on doing regular cycloplegic refractions before you start them on atropine. So I think what these pre-myopes truly need is a very close follow-up for at least 6 months, and in some of the cases where you feel that they are very quickly losing myopia, you can have a follow-up in 3 or 4 months. Second most important thing is to always suggest them environmental modification before you can actually think of starting any treatment. Increase outdoor time to 2 hours per day on an average, and reducing the near work. So near work typically is beyond 25 centimeters. If they are going very close to the television or very close to the mobile, or even while reading or writing, if they are going very close to the object of interest, which is more than 25 centimeters, then the chances of these pre-myopes progressing towards myopia is very high. And therefore we have to understand that we have to, number one, we have to follow them up. Number two, we have to tell them that increased outdoor time is very important, and reduced near work is equally important. So these three things are very important. When to start low concentration atropine? Low concentration atropine is mainly to delay the myopic onset, but there are two important criteria which we should follow. One thing is we should have an assessment of what are the risk factors, and second, which is not included in this risk factor, is how quickly they are losing out on myopia, which we saw in the second part of it. What is the progression? So both the things are equally important. Number one is on the first visit. Why there are two different things is that, number one, when the patient visits to you first, and if you feel that this particular patient is more susceptible towards going into progression or towards going into becoming a myope, you can call them after 4 months or 6 months, tell them to start the lifestyle modification things, and when they come back, you can take compare your axial length with the basic or baseline axial length that you had taken when the patient had visited first to you. So once you have the fact that he is progressing axially over a period of time, you can start low dose atropine. Peripheral defocus lenses, yes, more systematic studies are needed. We need more evidence, but once the patient is at minus, suppose the patient starts with plus zero point 0.5, goes to 0 and goes on to become a myope of minus 0.75 or minus 1, and you have already started atropine and this particular patient is not responding. Typically these are patients who are not responders, non-responders to atropine. Parental myopia is there, onset of myopia is very at a very young age. You can put them on peripheral defocus lenses which will come to you even in the power of minus zero point 0.5, minus 0.75 or minus 1. So you can get, you can do a combination therapy very quickly, because you know that you have to keep the numbers, each diopter counts, and you have to keep the number as low as possible. So that was regarding the pre-myopia. And this is the same sheet which we saw while in chapter 2 of documentation. You have to take the history pre-myopes between 6 to 10 years, plus 0.75 to minus point. This is a very good guide because you can easily quickly recap everything: behavioral recommendation, reduce the time on near-based activities, eye examination, closer follow-ups, and at 6 months eye examination, cycloplegic refraction, axial and measurements. And if you see that patient is losing out the myopia, losing out the hypermetropia, I'm sorry to say, the hypermetropia very quickly, you can definitely start considering some of the treatment modifications or some of the treatment modalities. And if you feel that that modality is not working, we can start the combination therapy, because some of these patients are really difficult, and they are they are non-responders and very difficult to treat with low concentration atropine. So you can always increase the concentration of atropine in these children who have presented to you early. So thank you so much. With this we come to the end of this, and we will meet on Thursday. I will post the Zoom link, and we will be discussing the paper which has all the risk factors. Mainly the three things. One is the baseline SER, that is spherical equivalent. The second thing is axial length progression, and the third thing is axial length upon CR ratio. So thank you so much uh, for the attention, and we will meet on Thursday. Thank you.